Welcome everyone. Today we will discuss about pulmonary hypertension and association with connective tissue diseases. We will discuss about the new definition of pulmonary hypertension and classification as per 2022 European Society of Cardiology and European Respiratory Society guidelines, how to screen patient with connective tissue diseases for pulmonary hypertension, how to interpret echocardiogram findings, and how to treat patient with pulmonary arterial hypertension. Right heart catheterization is required to confirm a diagnosis of pulmonary arterial hypertension. As per 2015 ESC/ERS guidelines, pH is defined as a mean pulmonary artery pressure of more than 25 mmHg at rest, with a pulmonary arterial wedge pressure of less than 15 mmHg, and additional diagnostic criteria may include pulmonary vascular resistance of more than 3 Woods unit. The definition of pulmonary hypertension are based on hemodynamic assessment of right heart catheterization and has been updated by ESC/ERS 2022 guideline, and pulmonary hypertension is defined as mean pulmonary artery pressure more than 20 mmHg at rest, with mean pulmonary arterial wedge pressure of less than 15 mmHg and additional criteria of peripheral vascular resistance more than 2 Woods unit. Pulmonary hypertension is divided into 5 clinical groups with several subgroups. Group 1 include pulmonary arterial hypertension, Group 2 pulmonary hypertension due to left heart disease, Group 3 pulmonary hypertension due to lung diseases, Group 4 pulmonary hypertension due to chronic pulmonary artery obstruction, Group 5 pulmonary hypertension due to unclear causes or multifactorial mechanism. Group 1 pulmonary hypertension is designated as PAH and has several subgroups that include associated PAH, idiopathic PAH, drug-induced PAH, and heritable PAH. Associated PAH is linked with connective tissue diseases and other causes such as HIV, portal hypertension, congenital heart diseases. Idiopathic PAH is the most common subtype, followed by PAH associated with connective tissue diseases. Molecular pathways in pulmonary arterial hypertension, such as prostacyclin mediated, endothelin 1 dependent, nitric oxide driven pathways have been postulated, and this resulted in newer targeted therapies in pulmonary arterial hypertension. Pulmonary arterial hypertension is commonly seen in patients with systemic sclerosis and is a leading cause of mortality. Screening starts with a thorough history, clinical examination, and non-invasive screening tests such as echocardiogram, NT-proBNP, pulmonary function test. Symptoms are mainly linked to right ventricular dysfunction and typically associated with exercise in the earlier disease. It includes dyspnea on exertion, dyspnea when bending, exertional chest pain, syncope, reduced exercise tolerance, weakness and fatigue, and ankle swelling. On general physical examination, you will find a raised JVP, ankle edema, and on systemic examination, left parasternal lift, loud second heart sound, systolic murmur of tricuspid regurgitation, and ascites. A variety of screening tools are available for PAH associated with systemic sclerosis. These include DETECT algorithm, 2022 ESC/ERS guidelines screening strategy, and 6th World Symposium on PH recommendation. DETECT algorithm is a two-step process. It's available online calculator. In the first step, there are 6 non-echo variables. These include FVC to DLCO ratio, current or past telangiectasias, serum anticentromere antibodies, serum NT-proBNP, serum uric acid, and right axis deviation on ECG. So when we put these variables into the online calculator, it will give us a score. So if the score is more than 300 points, echo is recommended. We will proceed with echo in step 2. Once we get our echo, there are 2 variables we need to enter into the online calculator. These include right atrium area and tricuspid regurgitation velocity. When we put these 2 variables, then it will give us a score. If score is more than 35 points, it means that referral for right heart catheterization is recommended. As per 2022 ESC and ERS guidelines, in patients with systemic sclerosis, an annual evaluation of risk of having PH is recommended. An adult patient with systemic sclerosis of more than 3 years duration, FVC of more than 40% and DLC of less than 60%, DETECT algorithm is recommended to identify asymptomatic patient with PAH. In patient with systemic sclerosis where breathlessness remains unexplained following non-invasive assessment, right heart catheterization is recommended to exclude PAH. Screening strategy as per 6th World Symposium on Pulmonary Hypertension recommendation says that annual screening for PAH using pulmonary function test and echocardiography should be considered in patients with systemic sclerosis spectrum of diseases with uncorrected DLCO of less than 80% of predicted. You can see different chambers and walls of the heart, including right atrium, right ventricle, tricuspid wall, and blood flow from the right ventricle into the pulmonary artery. Echocardiogram is a valuable non-invasive tool, and the most widely used echo parameter is the tricuspid regurgitation velocity. As per the current guideline, it is recommended to maintain the current threshold of tricuspid regurgitation of 2.8 meter per second for echocardiographic probability of PH, and assign an echocardiographic probability of pulmonary hypertension based on abnormal tricuspid regurgitation velocity and the presence of other echocardiographic signs. Based on the probability of PH by echocardiography, further testing should be considered in the clinical context. This is a diagram of the heart showing tricuspid regurgitation and blood flow into the pulmonary artery. Echo is the first-line non-invasive diagnostic investigation in suspected pulmonary hypertension. How to interpret echo? Tricuspid regurgitation velocity is the most widely used echo parameter. A peak tricuspid regurgitation velocity of more than 2.8 may suggest pulmonary hypertension. However, pulmonary hypertension cannot be determined by tricuspid regurgitation velocity alone. Hence, additional echo variables are used to define echo probability of pulmonary hypertension, which are then determined as low, intermediate, and high probability. Tricuspid regurgitation velocity can be grouped into 3. The first one is when tricuspid regurgitation velocity is less than 2.8 or not measurable. Tricuspid regurgitation velocity more than 2.8 but less than 3.4. Tricuspid regurgitation velocity more than 3.4. In the first category, if TRV is less than 2.8 or not measurable and 2 or more than 2 echo categories are not present, then this is assigned into a low risk probability. If 2 or more than 2 categories are present, then this is assigned into intermediate probability. If tricuspid regurgitation velocity is more than 2.8 but less than 3.4 and 2 or more than 2 echo categories are absent, then this is assigned into intermediate probability. But if 2 or more than 2 categories are present, then this is assigned into a high probability. Tricuspid regurgitation velocity if more than 3.4, then we don't need further echo parameters, and this is directly assigned into a high probability for pulmonary hypertension, and these are the patients who are referred for right heart catheterization. So what are those additional echo variables which we use along with tricuspid regurgitation velocity to assign our patient into low, intermediate and high probability? So these are related to the ventricles, pulmonary artery and inferior vena cava and right atrium. In ventricle there are three variables. You can see a normal heart with normal LV and RV and a dilated RV compared to LV in pulmonary hypertension. Dilated RV result in RV to LV basal diameter ratio of more than 1. There is flattening of the interventricular septum. This leads to a D-shaped left ventricle, and as a result the LV eccentricity index is more than 1.1. Top C to systolic pulmonary hypertension ratio less than 0.55. In pulmonary artery there are three variables: RV outflow Doppler acceleration less than 105, pulmonary regurgitation velocity of more than 2.2, pulmonary artery diameter more than 25 mm. In inferior vena cava and right atrium there are two variables: inferior vena cava diameter more than 22 mm with decreased inspiratory collapse, right atrium area more than 18 cm square. These are the different variables related to ventricle, pulmonary artery, inferior vena cava and right atrium shown together in this slide. Other additional blood tests include baseline test, BNP, serological studies and immunology, pulmonary function test, chest radiography, CT chest, VQ scan, cardiac MRI, and right heart catheterization for confirmation of pulmonary hypertension. Treatment could be in the form of supportive treatment or targeted therapies. Supportive treatment include diuretic for right ventricular overload and peripheral edema, oxygen, anticoagulation, role of which is controversial, calcium channel blocker in patient with vasoreactivity on right heart catheterization, immunization, and treatment of the underlying condition. Pulmonary hypertension is mediated by different pathways, and drug therapies are directed against these different pathways, which include prostacyclin pathway, endothelin pathway, and nitric oxide pathway. Drugs in prostacyclin pathway include oral, inhalational therapies, and parenteral therapies, while endothelin receptor antagonists include ambrisentan, Bosentan, Macetentan, and nitro oxide pathway include phosphodiesterase inhibitor and guanylate cyclase stimulator. Patients are stratified into different risk categories. Patients with cardiopulmonary comorbidity are commenced on monotherapy, while patients with low to intermediate risk are commenced on combination therapy with ERA or phosphodiesterase inhibitor. Patients with intermediate to high risk are commenced on parenteral epoprostenol plus ERA or phosphodiesterase 5 inhibitor. Phosphodiesterase inhibitor or ERA, either as monotherapy or in combination, are typically used as a first-line treatment. Thank you very much for listening.